for another new session on the physiology of basal ganglia. So let me tell you that basal ganglia, right? This basal ganglia, though the basal ganglia does not directly helps in performance of any movement, but movements are not possible without basal ganglia, right? Movements are not possible without basal ganglia. So whatever the background postural support is going to be there, the background postural support is going to be there, it is going to be with the help of the basal ganglia, right? So let's get started. So let's start our topic today with a simple case study. Okay, this is a simple case study which will help you to better have a clinical orientation or a clinical integration, right? Because you know what is like when we are preparing for our first MBBS university examinations, at that time we are not aware of what could be the symptoms when the patient is coming with basal ganglia. And nowadays if you see that the questions are going to be clinical oriented, right? The questions are going to be clinical oriented, so it is always have to have a primordial effect on ourselves, like what are the symptoms the patients can have when he will be suffering from disease with basal ganglia. So here is the case history of a 63-year-old man who is brought to the primary physician because of the concern from his family, and he's coming with the symptoms of worsening of tremors at rest. So this is the important point, that there are worsening of tremors at rest, there is difficulty in walking, and another thing is has difficulty in stopping also. So difficulty at the start of movements and difficulty at the stop of movement, important things to be remembered, right? There is no personal history, there is no family history, right? On examination, there is a mask-like face, there is a very conspicuous pill rolling tremor, a muscular rigidity, a stooped posture, as if the person is going to fall towards the center of gravity. And he does not show any signs of dementia or depression. Now, because we have already studied, we know that this is Parkinson's disease. But for the ones who are going to study for the first time in the MBBS, you should know that this 63-year-old man who is presenting with muscle rigidity, who is presenting with resting tremor, who is presenting with a difficulty in walking, is consistent with the Parkinson's disease. Okay, so here you get this old man having the typical symptoms of Parkinson's disease. What is a typical gait? As if he is falling towards the center of gravity. He's got a mask-like face, as if there are no expressions. There is rigidity, there is freezing, there is a postural instability, shuffling steps, which we also called as the short baby steps, and very important is a resting tremor. Resting tremor is very important, which is to be considered. Okay, so with this, let's get started to our first topic today of the morning, that is basal ganglia. Okay, so this is the topic of the morning, that is basal ganglia, which is also called as the accessory motor system, which is also called as the accessory motor system, right? Now, what are the different components of this basal ganglia? This basal ganglia, right, it has got the caudate nucleus, putamen, okay, caudate nucleus, putamen. There is globus pallidus. Globus pallidus itself has got two portions. There is internal segment, there is external segment, right? Then there is substantia nigra having two components, pars reticularis and pars compacta. Pars reticularis and pars compacta. And a very important nuclei, that is the subthalamic nuclei. Subthalamic nuclei. Now if I ask you a question, that which is the only excitatory nucleus or excitatory part of basal ganglia? Among the caudate nucleus, putamen, globus pallidus, subthalamic nucleus or substantia nigra, which is the only excitatory nucleus? Yes. So the correct answer is the only excitatory nucleus over here is the subthalamic nuclei. Rest all of them are inhibitory, and its neurotransmitter is glutamate. Its neurotransmitter is glutamate, right? So excitatory nucleus is subthalamic nuclei with the neurotransmitter glutamate. Now you know basal ganglia, like that of cerebellum, it has got a very complex neural circuitry. Okay, there is a very complex neural circuitry that is actually responsible for the start or stop of the movement or for maintaining the motor movements. Now before I explain you that neural circuitry, you have to just try to answer this MCQ. Which of the following provide the predominant input to the basal ganglia, which is the output from the basal ganglia, and which is the direct synaptic target of the basal ganglia? Yes, anyone can answer? A, B, C, D or E? Anyone can answer this, that which is the input, or where are the inputs coming to the basal ganglia? Where are the outputs going from the basal ganglia? And in the basal ganglia, who is the direct synaptic target? So the correct answer is D, right? All the inputs that are coming to the basal ganglia are from the the correct answer is C. Okay, all the inputs that are coming to the basal ganglia are from the cerebral cortex, right? The inputs that are coming to the basal ganglia are from the cerebral cortex. The output is going to the thalamus, right? So the inputs are from the cortex, right? The output are going to go to the thalamus, and the targeted nuclei is the globus pallidus, right? The targeted nuclei is the globus pallidus, right? So let's first study this circuit or this neural circuitry before we go on to the depth of the topic, learning the excitatory direct pathway, the inhibitory indirect pathway, or the Putamen circuit and the caudate circuit. So before we rush on to that, let's first get ourselves acquainted with this different components in the basal ganglia and their circuit. Right? Now, these dark lines are excitatory, or you can say that the solid lines are excitatory and these dashed lines are inhibitory, right? They are inhibitory to start with. Now you can see that the inputs are coming to the striatum. What is striatum actually? Striatum is actually caudate nucleus plus putamen. Caudate nucleus plus putamen, right? So the inputs are coming from the cortex and they are coming from the thalamus. The inputs are coming from the cortex and they are coming from the thalamus, and they are mainly excitatory. Okay, they are mainly excitatory. You can see that it is glutamate is the neurotransmitter and acetylcholine is the neurotransmitter. So basically the inputs which are coming are excitatory, which is glutamate and which is acetylcholine. Now after they come to the striatum is now going to start, right? What it will do, you can see that the striatum sends inhibitory inputs to the substantia nigra pars reticularis, right? The striatum is giving inhibitory inputs to the substantia nigra pars reticularis because the inhibitory neurotransmitter here is GABA. Okay, the inhibitory neurotransmitter here is GABA. Now the substantia nigra pars reticularis is inhibited by the striatum, but the substantia nigra pars reticularis, this is pars compacta, okay, the substantia nigra pars compacta sends inputs to the striatum which are both excitatory as well as inhibitory. So basically they are going to the putamen. Basically they are going to the putamen. Excitatory is D1 and inhibitory is D2, dopaminergic receptors. Dopaminergic receptors. Okay, so here comes the role of dopamine. So substantia nigra pars compacta can stimulate the striatum as well as it can inhibit the striatum, and when it is acting, when dopamine is acting through D1, it is going to be excitatory, through D2 it is going to be inhibitory. Right? Now the striatum also, okay, what is the striatum doing? The striatum is also sending inhibitory impulses to globus pallidus external segment. Right? So it is again sending its GABAergic fibers, it is again sending its GABAergic fibers to globus pallidus external segment. Globus pallidus external segment in turn inhibits the globus pallidus internal segment, and it also inhibits the subthalamic nucleus. Right? The globus pallidus external segment, what it is doing, it is inhibiting the globus pallidus internal segment, and also it is inhibiting the subthalamic nucleus. But I told you that subthalamic nucleus is the only excitatory nucleus, right? The subthalamic nucleus is the only excitatory nucleus, and this subthalamic nucleus stimulates both globus pallidus external segment as well as globus pallidus internal segment. So these three, that is the striatum, right, the striatum, the globus pallidus and the subthalamic nucleus, these are the three things which are actually responsible for the initiation of the movement or for the stopping of the movement, and they are being controlled by the striatum, especially the putamen, especially the putamen. So again, to revise, the striatum is sending inhibitory GABAergic fibers to globus pallidus internal segment, which in turn is inhibiting the subthalamic nucleus. But the subthalamic nucleus excites both the globus pallidus internal segment as well as external segment. The final output is given by the globus pallidus internal segment to the thalamus. Okay, the final output is by the globus pallidus internal segment, This is given basically to the thalamus. That means though the inputs that are coming to the basal ganglia are excitatory, okay, though the inputs that are coming to the basal ganglia are excitatory, but the outputs that are going from the basal ganglia are inhibitory. They are inhibitory to the thalamus as well as to the pontopedunculaire nuclei or the pedunculopontine nuclei. This PPN is the pedunculopontine nuclei, right? So what we have to remember, that the inputs are basically excitatory. The inputs are basically excitatory, but the output from the basal ganglia is basically inhibitory. Okay, the output from the basal ganglia is basically inhibitory. Now let's move into a bit depth of the circuits. This is the caudate loop or the caudate circuit, which is actually responsible for the cognition or the cognitive process. What is cognitive process? Like any new sensory information is coming to the brain, right? Any new sensory information is coming to the brain, and the brain can now think about it. It can also compare with already old information it had that is stored in the memory. Right? So the new information and the old information. Now suppose you see a fire, right? Suppose you see a fire. Before you run or before you put water, like before you bring about the physical component of that, there is going to be a cognitive component. So that cognitive component will be brought about by the caudate loop. How is this caudate loop? This caudate circuit, it receives inputs from the supplementary motor area, sensory area, and let me tell you, it receives lots of inputs. Okay, it receives lots of inputs from the association areas. It receives lots of inputs from the association areas. Okay, so they are coming to the caudate nucleus. Again, globus pallidus internal segment and substantia nigra pars reticularis. Let me tell you one thing, that the globus pallidus internal segment and the substantia nigra reticularis, they function together, or they are functionally a single entity, right? They are functionally a single entity, whereas the globus pallidus external segment and the substantia nigra compacta, they are functionally a single unit, or they function together as a single entity. This is something important, and you can see that it is mainly going to the ventrolateral nucleus. Okay, ventrolateral nucleus of the thalamus, right? So what is the role of this caudate nucleus? This caudate nucleus, which receives lots of inputs from the association areas, basically helps in the thinking, okay, which we will elaborate it a bit more when we study the functions of basal ganglia. So caudate loop is receiving inputs from the cortex, but there are lots of inputs coming from the association areas, going through the caudal part of the globus pallidus internal segment and the substantia nigra pars reticularis to the motor nuclei of thalamus, that is the ventrolateral. So this is the caudate loop. The second one which we have is the putamen loop. Now this putamen loop is very important in the execution of movements, very important in the execution of movements, in the timing and scaling the intensity of movements, scaling then the intensity of movements, and we should just compile these when we study the functions, right? Now this putamen loop is receiving impulses from the frontal association area. It will also receive from the primary motor area, also from the premotor area. Now you can see that they are also going to the same nuclei, that is the globus pallidus internal segment and the substantia nigra pars reticularis, but to the rostral part, okay, to the rostral part. Whereas in the caudate circuit, they were going mainly to the caudate part. Okay, we can just have a quick recap. See, here you can see that in the caudate loop, C for caudate, C in the caudal part, whereas here they are going mainly to the rostral part. That means both of these loops, they are going to go to the same areas, but in the same areas, the caudate is going to go to the caudal part and the putamen is going to go to the rostral part, right? And from there they go to the thalamus. Now thalamus in the caudate circuit, it was mainly the ventrolateral nuclei. This is mainly the ventro-anterior nuclei, okay? The ventro-anterior nuclei. From back, they are going to go to the frontal areas, to the premotor, primary motor, and even the area number 4. So the inputs are coming from the cortex, getting processed in the putamen, globus pallidus, substantia nigra. Finally, they are leaving out through the thalamus and going back to the cortex, right? So these are so first, what did we study? We studied the basic circuit which is present, okay, the basic circuit which is present. Then we elaborated by knowing that how is the caudate circuit and how is the putamen circuit. Now we will study what we called as the direct pathway and what we called as the indirect pathway, which are important for the excitation and which are important for the inhibition or the start or the stopping of movements. And let me tell you that this is via the D1 dopaminergic receptors and this is via the D2 dopaminergic receptors, right? So what are the different components of these pathways, right? What are the different components of these pathways? Now let's get started first with the direct pathway. The direct pathway is supposed to be the pathway which is facilitatory, which is going to facilitate the movements, right? So I am first going to teach you the direct pathway. Now let it make it very, very simple in the form of a flow chart. How are we going to make it simple? See, this pathway starts from the striatum, right? Then there is globus pallidus internal segment, and there is substantia nigra pars reticularis. I already told you that this globus pallidus internal segment and the substantia nigra pars reticularis, they function as a single entity, okay, or functionally they work together. And then there is going to be the thalamus, right? So this is excitatory. And how it is excitatory? Let us make it very, very simple. Something briefing, you know that this striatum has actually very little background activity. This is one point, that the striatum has got very little background activity. This is point number A to be remembered. The point number B is that globus pallidus internal segment has got a natural or an intrinsic effect to inhibit thalamus, right? That means if the globus pallidus internal segment is not inhibited by anyone, it is always going to inhibit the thalamus, right? It is always going to inhibit the thalamus. Now, when we start the movements, what occurs? Right? When we start the movements, or even this basal ganglia is responsible in the planning and programming of movements. So when we speak about planning and programming of movements, actually if you see, the discharge from the basal ganglia starts even before the movement has been started, okay? The discharge from the basal ganglia starts even before the movement has been started. So when we start any movement, there is going to be excitation of the striatum from the cortex. We have already seen that in the first slide, that the cortex is going to excite the striatum, right? So once this cortex is excited, or it has excited the striatum, this striatum is going to inhibit the globus pallidus. It is going to inhibit the globus pallidus. So because now this component has been inhibited, right? There has been inhibition of this component. There is basically no disinhibition. There is no disinhibition of thalamus. Thalamus is now free, right? Thalamus is now free to bring about its activity, right? Because what we have done, the cortex, okay, the cortex had sent excitation to the striatum, and striatum has inhibited the globus pallidus internal segment. Now because the globus pallidus internal segment has been inhibited by the striatum, it is not able to, okay, it is not able to inhibit the thalamus. So because now it is not inhibiting the thalamus, this pathway becomes the excitatory pathway, okay? This pathway becomes the excitatory pathway. So it is very easy, the striatum having no background activity of its own, but when at the commence of the movements, striatum is activated by the cortex, striatum getting activated inhibits the globus pallidus internal segment. Because the globus pallidus internal segment is inhibited, it is no longer able to inhibit the thalamus. So this is how there's going to be the initiation of movement. This is how there's going to be the initiation of movement, right? Now, next let us see the D2, that is dopaminergic. When it acts through D2 receptors, it is going to be an indirect pathway. This indirect pathway is actually an inhibitory pathway that is going to inhibit the movements. So how does this occur? Now for this pathway, you should understand that there is now the need of another nuclei, because what did we do? We actually did not we directly inhibited the globus pallidus internal segment. Okay, what did we do? We inhibited the globus pallidus internal segment, and because of this we could bring about the start of movement. Now if I want that the movement should stop, I have to change the discharge from the globus pallidus internal segment. I have to now change the discharge. That means initially I inhibited the globus pallidus internal segment, but now I will have to stimulate the globus pallidus internal segment, so that when it is stimulated, it is going to bring about the stoppage of the movements, right? So how will this happen? See, this inhibitory pathway is from the striatum. It involves the globus pallidus external segment, but it has to now involve the excitatory subthalamic nucleus. It is have to now involve the excitatory subthalamic nucleus, so that this subthalamic nucleus can excite the globus pallidus internal segment, so that finally this globus pallidus internal segment is able to inhibit the thalamus. So at the starting of the movement, what did we do? We inhibited the globus pallidus internal segment. Because we inhibited the globus pallidus internal segment, it was not able to inhibit the thalamus. Now we have to request this globus pallidus internal segment that please go and inhibit thalamus, and for this requisition we will take the help of subthalamic nucleus. So how it is going to occur? Striatum, which is going to be again excited by the cortex. Once excited by the cortex, it will inhibit the globus pallidus external segment. Once the globus pallidus external segment is inhibited, it is no longer able to inhibit the subthalamic nucleus, right? So when the globus pallidus external segment is inhibited, it is no longer able to inhibit the subthalamic nucleus. That means the subthalamic nucleus is now disinhibited. Okay, it is disinhibited. So because it is disinhibited, it can now stimulate the globus pallidus internal segment. Once this globus pallidus internal segment is stimulated, it is always going to send inhibitory discharge to the thalamus. It is always going to send inhibitory discharge to the thalamus. So this is very, very important when we are going to stop the movement. I hope I was very, very much clear in explaining you first the plain or the simplest circuit which occurs in the basal ganglia. Then we looked over to the caudate loop and to the putamen loop. Then we have seen the direct or the excitatory pathway and the indirect and the inhibitory pathway. Now let's compile the functions of basal ganglia. Right? Now let's compile the functions of basal ganglia before we move forward and before we look into some pathology. So when we speak about the functions of basal ganglia plays a very, very important role in the control of motor activity. Okay, in the control of motor activity. Right? It plays a very, very important role in the control of motor activity. It is important in the cognitive control. Okay, it is important in the cognitive control via the caudate loop. And let me tell you that if there is any lesion of the caudate loop, if there is any lesion of the caudate loop, there is kind of akinesia. What is akinesia? Yes, paucity of movements. There is very difficult to switch from one program to another. There is very difficult to switch from one program to another. That means you cannot shift from one voluntary activity to another. That is akinesia with the lesion of the caudate nucleus, right? Then I told you there is the putamen circuit or the putamen loop. This putamen loop is very, very important for the timing of movements and the scaling of movements. What do you mean by timing of movements? How rapidly the movements can be performed. How rapidly the movements can be performed. And what do you mean by scaling? How large the movements can be performed. How large the movements can be performed. For example, suppose you have given me one piece of paper. This is this much. Now you have given me a paper which is this much, or you have given me a paper which is as big as this screen, and you ask me to write A. So this will be my A, this will be my A, but if the area is increased, this will be my A. So this is the scaling of the movements. So when the movements are scaled, like if you scale the intensity, scaling of the movements, they could be small, they could be large. So depending upon that, it depends about how many joints you are using. If you are writing very small, so you are just using your fingers or your wrist, and it comes to bigger movements, then your elbow, your shoulder, all will be involved. That means you will have to incorporate not only more joints but also more muscles. So this execution of a learned pattern of movements, this execution of the movements or the learned pattern of movements requires the role of the putamen circuit, right? How fast the movements can be performed? See, I can write like this, or I can write like this, or I can write even more faster. So this timing and scaling of the movements is with the help of the putamen circuit. Then another important function is the associated movements. What is associated movements? Like the swinging of arms when we are walking, right? Another important thing is like when we are swimming, there is a proper coordinated movements of the arms and legs. So these associated movements are very, very important function, or the subconsciously the movements which we are doing is because of the help of the basal ganglia. Basal ganglia plays again a very, very important role in multitasking movements. Like what? Like suppose I am driving and at the same time I am talking, but still I reach my home, isn't it? But still I reach my home. So these multitasking movements are with the help of the basal ganglia. Okay, basal ganglia, as I told you, plays a very, very important role in the planning and programming of movements. Okay, it plays a very, very important role in the planning and programming of movements. So you can see this circuit from the cortical association area going to the basal ganglia and also going to the cerebellum. Which part of the cerebellum? Neocerebellum or the lateral cerebellum, to the motor cortex, to the execution of movements, and the copy of the execution of movement, like what we are performing, are going back to the spinocerebellum to compare whether the ongoing movement is correct with the movement that was planned. Okay, then basal ganglia also helps in procedural memory. Right? Suppose if I ask you how to put a vasofix, or extracting a tooth in the case of a dentist. So learning any new procedures is also the role of basal ganglia. Right? Learning any new procedure is also the role of basal ganglia. You can see classically the type of the tremors which we get in the patient with Parkinsonism. These are the pill rolling movements which you get in the patient with Parkinsonism. You can see the handwriting of the patients with Parkinsonism. Can you see the timing and the scaling, the non-coordination of the movements, isn't it? So basal ganglia plays a very, very important role as an accessory motor system in the control of reflex muscular activity, muscle tone, reflex muscular activity, right? Then, so just let me put this question in front of you. A 62-year-old nursing home patient is brought to emergency for evaluation of an altered mental status. MRI was done, which showed the degeneration of the neurons in the substantia nigra. This loss is mostly because of which of the following? So, A, decrease activity in the basal ganglia output nuclei, or it produces dyskinesias like chorioform, hemibelesmus, suppress the activity in the subthalamic nucleus, suppresses the direct pathway and facilitate the indirect pathway. So what is the correct answer? E. That is, the degeneration of the dopaminergic neurons suppresses the direct pathway and facilitate the indirect pathway. So under normal conditions, dopamine released by the neurons, dopamine released by the neurons in the substantia nigra affects both the direct and the indirect pathways, it affects both the direct and the indirect pathways in the motor loop, exciting via the direct pathway and inhibiting via the indirect pathway. So if the dopamine containing neurons degenerate, if the dopamine containing neurons degenerate, like what occurs in the Parkinson's disease, the excitatory actions on the thalamus are inhibited, but there is less disinhibition of the inhibitory actions. So what is the consequence? That excitation from the thalamus to the motor area is decreased, and it becomes very, very difficult to initiate the movements. That means a total imbalance between the excitation and inhibition, a total imbalance between the excitation and inhibition. Now, a common thing which we come across is a lots of confusion between what is spasticity and what is rigidity. So I have just created a table for you. Remember that spasticity is because of the lesions in the pyramidal tract, and the commonest site is the internal capsule, whereas rigidity is mainly because of the lesion in the basal ganglia, and therefore it is called as the extrapyramidal rigidity. The muscles involved are here either agonist or antagonist will be involved, but here both agonist and antagonist are involved. How is hypertonia? It is basically a clasp knife type of hypertonia, right? That is passive flexion initially and then marked resistance, but then there is a sudden completion of movements. A clasp knife, as you open and you close the clasp knife, right? Whereas here it is basically a lead pipe rigidity. That means a uniform resistance, a uniform resistance to flexion, as if the person is bending a lead pipe. Now, spasticity is stretch sensitive, and here it is not stretch sensitive. So these are important features regarding the differentiation between spasticity and rigidity. So with this we come to an end. You know that basal ganglia is highly developed in the birds. So remember, until you spread your wings, you never know how far you can fly. So it doesn't matter if you start on the rocks or on the rooftops, just spread your wings and let them carry you to the new heights. Keep studying, take more time to rejoice, to restart, to refocus, and always rejoin for the sessions. So with this we come to a conclusion of basal ganglia. Happy learning everyone. Have a great day.